Here we go. Okay, so we're going to start with the deltoid, and if you're following along in your module, we're in module number 7. And if you are following along in a textbook, can someone call out a page for the new edition? Deltoid?
I got 67.
All right, thank you. So if you're on a new edition, we're on page 67. All right, so the basic information about these muscles is going to be reviewed because we did do kind of an overall lay of the land, but now we're going to add in origins, insertions, actions, layers of muscle, and more detailed information about how to palpate them. But do keep in mind that we will have lots and lots and lots of massage labs. So we'll really get a good feeling of this in our hands in our different labs. So the deltoid is, you know, what some people would call the shoulder cap. And it's very, you know, very prominent, easy to palpate and easy to see and feel muscle. In my model, it's in orange right now. My kid did this one. And if you put your hand on top of your shoulder, it's this entire muscle here. And as one of the superficial muscles, so closer to the surface, you know, it's one of the muscles that, you know, tends to get sort of exaggerated or highlighted in anime characters, superheroes. You know, they show those kind of superficial big muscles. So that's our deltoid right here. And let's get to the details before I start kind of telling you more and more about the deltoid. Our deltoid is a powerful abductor, abduction. So let's everybody right now. I thought my computer completely died. Nope, it's my connection to the TV. That's fun. Okay, so this is a great, I love the side view or lateral view of the shoulder and the deltoid. And one of the things I really love about this view is that you can really see this wonderful origin that goes all the way from the lateral third of the clavicle, so the outer aspect of the clavicle, the acromion process, and then, you know, you can't see as well, but you can on the bottom picture, how much of the spine of the scapula. So we've got this great big broad origin. And the detailed words that talk about that, and we're down here, the origin is always the O. So this O for origin is the lateral 1/3 of the clavicle, the acromion, that outer process. Good job feeling it on yourself. And the spine of the scapula. And if you take a moment, you can walk your way around and feel all of those origins very clearly. Now, the thing about this origin I think is really cool is it's the exact same attachment as the insertion for the upper traps. So we will see that next. But if you feel, go ahead and feel right on those bones. When you're on the bone itself, you can hopefully feel how it is hard and slippery. And you walk your way around, there's a part of that V-shaped origin that does not have the muscle on it. So the deltoid attaches below it and the traps attach on top of it. So if you feel just below it and just on top of it and kind of go side to side now, you can feel kind of the ropey tendinous attachments of those muscles. And then there would be a connective tissue kind of weaving those things together. And one of the reasons I'm really calling this out is because those connective tissue connections, even though we study these muscles independently, they're very much connected, so that you can make a leap in your mind that if there's ever anything going on with deltoid, then you work your way up to traps because they have a direct connection, and vice versa with traps. You work your way right down to deltoid. Does that bring up any questions or comments so far?
You said it connected on the insertion, not the origin.
Deltoid's origin is trapezius's insertion. So this lateral third of the clavicle, which I'm going to draw on the bottom right now in red, lateral third of the clavicle, acromion process, and spine of the scapula, which I just drew in red, is the origin of deltoid and the insertion of traps. Question?
So is the trapezius the other muscle that helps abduct the humerus up top there?
That's a great question. You know, you'd kind of maybe make that guess, right, since they share that one attachment, but that attachment is actually not across to the glenohumeral joint. So the deltoid going down across this joint is what does that abduction, and the trap does other stuff. But great thinking.
All the way up. I thought you said it only goes to here.
It does, yep, and other things do. Yeah, and the traps do help with that upward part of the rotation. And so in that way, they are both connected to that movement, but the actual abduction part of it is the deltoids, not the traps.
That's why
But
it's not massive.
that, yeah, and then as we keep going, yeah, yes. Oh, you're just palpating, good job. Yes,
I will admit that my brain starts to swing on details. And I don't know what to do about that. Maybe part of that was like 2 a.m. and I was going from video to video.
yeah,
I'm like,
yeah.
I don't know who to what.
Yeah, well, thanks for sharing that. It's helpful for me to know your processes, all of you, and how you learn. If you think about these, looking at the module ahead of time is sort of a preview, but then I don't expect you to really understand it all until you work with me, and that hopefully this time together will help it also make more sense. Also, you're new to learning the details of the muscles, and I'm going to give you some tips that I hope will help. So let's take a look at this detail, for example, this origin. What you really want to do is when you read these words is to feel them, is to see them, is to picture them, whether it's on yourself, a model, a picture of paper, because what's most important is that it's in your hands, right? So rather than like all these words, right? You have to like really literally feel and picture, what do those words mean? And that's why we're walking through, like literally walking your hands all the way around. And now you like, I put my hand up here, I'm literally on the entire origin because my hand is all the way over here and here and here, and I'm feeling the whole thing. Yeah. So, you know, hopefully this will help over time, right? That's just kind of a first step. Does that,
I feel like for some reason I like last week what we did. I'm like, oh, that's the last week. Like, I don't know why I just went to
yeah.
And so it made me nervous because we're getting at a faster pace now. And I'm like, wait, I don't know if I remember what that was. And now I have to pay attention to this one.
Yeah. Well, and part of that is, it is a lot of details, right? Anatomy, physiology, kinesiology is a lot of details. So for most people, and it's kind of another language as well. Like we study anatomy and physiology, it's a lot of Latin and Greek. And so we'll literally study, as they do in medical terminology, the prefixes and suffixes so that you can decode these words. But it is another language. And so it takes a lot of time and practice, like learning another language. And so, yeah, last week's can't be last week's, right? Last week's is still this week's, and you just have to keep working with them. And so those Quizlets, while I only assign them once, are the kind of things that you can keep working with, yeah, along with your models and everything else. So let me quickly draw this origin up here. Top diagram, I'm now drawing the origin in red. So as a recall, what does the origin mean on a muscle? Where it starts, excellent. And anything else? What is the difference between an origin and an insertion? Yes, thank you. Excellent, Oksana. So the origin is the side that has less movement and the insertion has more movement. But here's another thing to help you have less memorization is that the origins are usually closer to the axis or the center, and the insertions usually are further out, like if it crosses to an appendage, to the appendage. Because of course it makes sense that the appendages, arms and legs, and even the top of the head are more movable, right, than the center. And so there are, we're going to look at some muscles that don't really cross in such an obvious way, but for a lot of them, that can be kind of help reduce your memorization and also your, help you think about them.
Immovable force and an unstoppable force.
I don't know what you're saying. I don't know the context.
The foundation,
Yep.
The origin,
Mhm.
immovable,
Mhm.
and the unstoppable force is your movement.
I'm not following, but if it helps you or anybody else, great. Yeah, no, I appreciate you thinking out loud. I'm not tracking what you're saying, but if it helps you and other people, great. Yep, not following that thought. I want to call out something for your licensing exam. And also if you study from other sources, you will see different wording sometimes. So they're not going to all say the exact same thing, which can add to sort of the confusion. So I would recommend you really focus your studies with your trail guide materials. And they do have an app. We've got all the resources in the module, and they also have flashcards, which you can borrow back there. Because if you start looking at other sources, it might confuse you that the wording is a little bit different. On your licensing exam, it might also kind of generalize or talk about part of it. They do not have to use the exact same words. I'm sorry that can seem scary or overwhelming or even more confusing. But they might say something like, which muscle originates on the spine of the scapula, clavicle, and acromion without saying like the exact total details. And it's multiple choice, so it will be the only one that's there. But it might not say the exact same like lateral third of the clavicle, etc. So it might say part of it. That's also true of the actions. So we're going to study every action of a muscle, but on your licensing exam, it may just call out certain ones, and you'll still need to be able to know, like, yeah, they're saying abduction, that's my deltoid, even though they didn't say all of the actions, right? And I just want to call that out from the beginning because I think it'll help you understand your studies. What's that? Yes, they would have to say abduction of the shoulder, right? And it's a multiple choice. So they might list a couple of the abductors, or they might just have one, but it'll be like the best choice, right?
So it could be different wording and also incomplete.
Yes, yes. So for example, it might just be the primary movement. So deltoid's primary movement is abduction, rather than listing that it also flexes, it also extends, etc. Yeah, does that bring up any questions so far? Beautiful job doing the movements and palpation. That's how most massage therapists learn. And even when you're taking your licensing exam, it's on a computer, but you can still be touching yourself and firing the muscles and doing the movements. Yes, Weekus.
How many questions are on the
100. Yep. What's that? Week 1, you got it. Yeah. I know it's scary, but we have a lot of time to study. And in our 3rd quarter, we have a class that's just practicing for the licensing exam, which includes taking lots and lots of online practice exams. So you get used to that computer format test. Yeah.
And they're multiple choice.
They are multiple choice. There's nothing written in. There are some pictures. I have to say probably the most, probably the most two difficult things about the test. Well, there's three most difficult things about the test. One is that they don't make the multiple choice questions as easy as I do. So I try not to throw in any confusing ones. I try to make it like the answer is obvious, and the real test will have more than one that's maybe sounding sort of right, and you really have to be confident about which is the most right. Another challenging thing about it is that it's the type of test where when you answer the easy questions right, it gives you harder questions. So it always feels like, oh my God, am I going to even pass this thing? Because you've already answered the easy ones and now it's going to throw harder ones at you. There is a time limit. Yep. Yeah.
We could take it though, like.
It's $200 to take it.
Did you say we could take the practice exam or something like that?
There is a practice one online. I think it's too early to take the practice exam, you know, and I was only telling you this information about how to study Kines. I don't think you have to worry yet. I see someone built an origin in red already on your, unless the last person did that. So good job. All right, so if you have a mannequin or a skeletal model that has red and blue on it, the reds are origins and the blues are insertions. That's sort of the traditional method, but they don't have every single one labeled. And I said this before, but you hadn't learned much at the time, and so it might make more sense now that I would not be a good kinesiology teacher if I didn't let you know that some kinesiologists now think we should call everything an insertion and not even distinguish between origin and insertion. But it's still industry standard to call origin insertion separately, and that's definitely still how the MBLEX tests you. Great question. Why would they do that? Some people think you shouldn't distinguish them because there are quite a few muscles where both sides move a lot. So that's kind of why. Yeah, it's not always clear which is less movable and which is more movable, but a lot of them are. Yes.
Small detail, start the other conversation.
Yep.
How long do you get on the test?
I think it's 90 minutes, but you can look it up online because I may be wrong. And if you have a documented disability, you know, you can, you know, opt in for time and a half on tests and things like that. But that has to be, it's a very formal process, of course, to go through. And that's through them, right? Not our disability services. All right, let's move away from that test, right? All right, so the deltoid tuberosity, you know, I introduced this before. It is approximately, some people say a third of the way down the arm, some people say a halfway, but you can feel that very big, obvious bulk of the deltoid, and where it goes down is kind of a flat attachment. It's not a bump or anything. And on a lot of people, it's very tender. I called this out before, but it's clinically important to us that I'm going to say again, that some origins and insertions are excellent places for massage. And in the case of the deltoid, you can really work out the origin. But the insertion is tender in a way where it's not very useful to try to work it out right there. So I would recommend, you know, the origin or the belly. And again, obviously we will have massage labs on that. Yeah, Anna.
Did you say that in general before, that you want to work on the origin? Is that what you said?
No, I said, you know, a lot of times the origin or insertion are great places, especially with bigger muscles, because there's not so much bulk.
There was a question on one of the homework pieces that asked specifically, is it better to work on origin or insertion? I think I said origin.
I would have to see the question.
One of the written ones where you.
Well, if it's the deltoid, then yes, it's the origin, because we're not massaging insertion, but that's not general for all muscles. Yep. So here we are on the deltoid, and again, that's the insertion, deltoid tuberosity, and not as great for massage as the origin here. It's useful when we study any muscles to look at the shape of the fibers, and that will help us in palpation and massage. So with this muscle, we have what's called a multi-pennate situation that is kind of like a lot of feathers. We have all these kind of multiple different fibers kind of coming together. And so you're going to feel like this bulkiness with it. Yeah. I'm still on the same first slide. Yeah. Or this slide with the origin, insertion, and action. Yep. There's a lot of details on this slide. We're going to hang out here for a little while. All right. So I want to call this out as you're looking at your trail guide or your PowerPoints that on these bony pictures, trail guide always has a picture where it shows kind of a shaded area. And that is, you know, the O for origin or the I for insertion. And it's useful to look at what is the actual shape of that, because in some cases, it's going to be like a smaller attachment. And in other cases, it's going to be attached to a whole major part of the bone. All right, let's move on to the action. So I always like to do origin and insertion before I do actions, because, you know, knowing where the muscle starts and ends and picturing that distance between the two being pulled on like tug of war or shortened, you can start to work through what directions are we going to be able to move here. So there are fibers that cross anteriorly or in front, posteriorly in the back, and on the side. And they even call those anterior, middle, and posterior fibers. So a muscle that crosses the joint in multiple directions like that can pull in different directions, right? So all of the fibers cross over the top. So all of the fibers, if we shorten the distance between here and here, all abduct, right? But it's different if we look at these anterior fibers. If I shorten between here and here, we can also flex the shoulder and medially rotate the shoulder and horizontally adduct the shoulder. That's my anterior fibers. Whereas in the back, I can extend, laterally rotate, and horizontally abduct. And can you see that those anterior fibers and posterior fibers are opposite actions? Flexion, extension, medial rotation, lateral, AD, AB, right? So that means they're antagonists to itself, right? So some muscles can be antagonists to themselves. So if we're going to abduct, all the fibers are acting, but if we're going to flex, anterior is firing or contracting, while posterior is relaxing and stretching, and then vice versa for extension. So make sense? Yeah, okay, cool. And we talked about this a little bit in a compression routine, but you know, you would think, I would think, you know, big, strong muscle, top of the shoulder, very visible, whatnot. It would be an obvious muscle to massage, but I noticed a lot of massage therapists focus too much on the center with the traps, rhomboids, ESGs. And I'm going to teach you how effective it is when you work on that deltoid, teres major, teres minor, lats, how it really gets all that center stuff to relax. Yes.
Also, the deltoid kind of feels like skin sometimes on a lot of, so it's kind of like figuring out where the muscle is to grab it. You know?
Yeah, it can feel hard to grab sometimes. It's a great point.
Sometimes it feels like it's like this big.
Oh, when it's smaller. Yeah. Yeah. So whatever size the muscle is, it can still hold tension, right? So we kind of have to learn how to work through whether it's kind of a bigger one or a smaller one. Yeah, and work through the layers. Yeah. So I'd say that's probably the trickiest thing with the deltoid is working through the layers, which we just started a little bit. Elizabeth did a great demonstration of that. Yeah. All right, cool. So I'm going to move on. I'm going to try. Here we have just some palpation kind of pictures. I would like to call out, since this chapter was our first one that included a palpation video, that if you haven't watched those yet, you definitely should. They're very well made, professional. The only thing is that, you know, he's calling out on some very developed people, right? Low fat, high muscle, right?
Yeah.
And he's also just kind of quickly, right, showing you, I mean, great overlay diagrams, they're beautiful, but he's kind of showing you like quickly, right? And we're really taking our time because as we're palpating all of those origins and insertions, we're feeling the fibers and releasing them. But great videos, even though he's kind of going through them quickly.
Deltoid and it was like flex, and it's almost like you didn't have skin.
Yeah.
You could see all of the muscle fibers.
I've never seen a deltoid like that. It was crazy.
Yeah. Yeah. Well, and it's great. Like if you haven't worked with a bodybuilder yet, right? It's great to kind of see the muscles like that. But then of course we'll learn how to palpate them on anybody. Yeah. Okay, so this next page, for all the muscles in the body kind of near each end of each section, Trail Guide has a great section where they talk about the synergists and antagonists. So what's a synergist? Thank you. The muscles that work together, right? So when we're talking about synergists, we always have to think about what action are we talking about, right? Because a lot of the muscles have multiple actions. And so in certain actions, they're synergists with certain muscles, and in other actions, they're synergists with other muscles or antagonists, right? So we're always first looking at the action. So these pages, I think, will make more and more sense as we learn more and more muscles. But even with our first muscles, I think it's useful to start looking at them, and I'm going to call some things out. So with our flexion of the glenohumeral joint, in other words, that ball and socket joint of the shoulder, our anterior front fibers of deltoid, as we just learned, work with these other muscles. But notice how all of these muscles are located in the same basic area, right? They're attaching across the glenohumeral joint from the front. Sometimes there'll be some kind of wrapping around patterns or things that are a little more, you know, difficult to kind of see. But a lot of times you can just really see that, oh yeah, of course, those ones in the front are going to pull forward. And I'm really calling that out because, again, I want you to be able to picture these things, which will decrease your memorization, but also help you when you're hands-on with clients, that you're not going to have to like think through every one. If you know that there's an issue with this deltoid in the front, you're just going to naturally go to all the other ones that are doing the same thing, and you're naturally going to go to all the ones that are doing the opposite thing. Does that bring up questions so far? Remote folks, you're awfully quiet today. Do you have any questions or comments?
No.
All right. All right.
It's easier to follow this online with what you're talking about, because I feel like when you get into the synergist stuff, it's in a different section in the book or something.
Yes, this is the end of this section.
Yeah.
Yep. All right. Oh, there's one comment in the chat. Okay, all good. All right, so here we're looking at extension of the shoulder, so pulling backwards, and that we're looking at the posterior deltoid fibers. And if you go ahead right now and put your hand on your deltoid in a way where your palm is on anterior fibers and your fingers are on posterior fibers, go ahead and flex and feel how that makes the anterior fibers hard, and extend and feel how that makes the posterior fibers hard. Yeah. And when you're doing the movement yourself, it's called active movement. So when you're massaging a client, it's okay to tell them to do active movements. Sometimes we're going to do the movements for them, which is called passive. And sometimes we're going to have them do the movements, which is active. So with our extension, again, you can see that these muscles that extend the glenohumeral joint, you know, we're talking about muscles that are on the back or posterior. And of course, they have to cross the glenohumeral joint in order to have that action. And this is one of those confusing cases here with the pec major. Let me try to explain this one because it seems counterintuitive. In extension, we can be talking about starting from all the way up here. So in this position, when you're starting very flexed, this is a position where pec major is now at an angle at which it can help extend. But when you're down here, it's not at an angle to keep extending. Yeah.
That's the Latissimus.
Yeah, our lats. Yep. All right, so in our horizontal abduction and horizontal adduction, so coming across the chest on the horizon is adduction, coming across the chest away is abduction. And here we're looking at our, if we come towards the chest, this picture on the right, we're looking at our anterior fibers. And if you feel the anterior fibers, as you do that, you can feel them get hard. And then as we adduct horizontally, abduct, you can feel your posterior fibers get hard. And what technique that we learned so far is this particularly useful knowledge for? All right, we learned a technique already. Hint, it was during the compression routine, where having the clients do these kind of movements while you're on them is helpful to know the movements. Pin and stretch. Yeah, you're showing a pin and stretch. Excellent. So this is why it's helpful to know what all the muscles do, right? Because if you know what it does, then you know exactly what movements to have the client go through for pin and stretch. And depending on the position of the client, sometimes we only have the option for certain movements, right? But this is something you want to get a good feeling for in your hands, and then you can kind of play with it organically too, and feel like, okay, what angle is really engaging that muscle? And of these fibers that are tight, what's the situation there? Y'all are doing a beautiful job here. And then here we have abduction away, abduction of the shoulder, glenohumeral joint. All of the fibers cross over the top. If you abduct and you can feel them get harder. And then you adduct, you can feel them hopefully get softer. If they're not getting softer when you do that, they're very tight, right? But they should get harder and then softer. Beautiful. Y'all have questions? All right. And here we have our lateral and our medial rotation. Let's start with medial rotation. Shoulder comes in, like when we do this. It's going to be our front fibers, right? Our front fibers are going to pull in this way. Beautiful. Great job palpating. And then our back fibers or our posterior fibers when we do that lateral rotation. And again, you can see our muscles here. We've got these ones crossing in the back are doing this lateral rotation. And these ones in the front, medial rotation. How and why are these ones here on the left, the bottom left? Is because they're actually crossing from the back to the front. So that's how they're able to do that. And what I'm talking about, because some of you can't see my screen, are the lats, teres major, subscaps, and pec major. They start in the back, but they cross in the front, and that's how they can do this. We'll address each muscle at a time, so we'll come back to that when it happens.
This is lat.
Yep.
I'm just trying to keep up with which slides you're on. You're crazy.
She's on page 7.
They're on page 7. All right. So that was it for the, mega details of that muscle. Are there questions so far? I can try me one more time. I'm going to pause our recording, see if it's going to behave now. And those of you that are on Canvas, it's the last deltoid page in Canvas, and it shows like a ripped bodybuilder on this picture that basically just, I've mentioned this before, but that the deltoid, when we talk about abduction of the glenohumeral joint, we can only go to 90 degrees with that movement. So that's what the deltoid does. To get any higher than that, we have to upwardly rotate our scapula like so. So anything higher than this scapula is going up. And so when we look at upward rotation of the scapula, that's what we're talking about. Like anything reaching overhead, that motion is crucial, right?
Would that be the serratus?
That does help. And the traps, we're going to jump right into the traps, and that's the first one that we're going to talk about that can do that. All right, deltoids are super, super strong at their job, and I lied. I'm now on the last page of the module. And the example I'm showing, I mean, they can do a lot of very strong things, but the example I'm showing is when a gymnast can hold themselves up on rings or anything else like this. Yeah.
Nice shoulders or lats?
The lats have to help with that too. There's a lot of muscles in action to hold. Like when we stabilize, we're actually using a lot of muscles, but the one as far as that actual abduction, right? The deltoids are strong in that. Holding your body while doing it. Wow, that's intense. Well, and what some people were speaking to already, like what other muscles are doing that, kind of gets into the next point to just think about that really every muscle, every movement we do is a coordinated activity, right? We're not doing these like isolated movements, right? And even if we are isolating one movement, we're having to stabilize other things. And in the case of the shoulder, even if I'm just flexing my shoulder, if I don't want anything else to move, I'm stabilizing my scapula. So even in seemingly straightforward moves, there's a lot of muscles holding on and preventing other movements, right? So we got a lot of coordinated activities going on here. Yes, and also there's some that are just going to fire just enough to like hold that down, right? Yeah. And sometimes those are weak. So here's a good clinical example that, if you see a client, and this is not uncommon, where their medial border of their scapula, so the side close to the spine, sticks up a lot. That's called a winged scapula, and serratus anterior is weak. It's not holding it down. So that's another great example of if you know the movement that the muscle does. Like a lot of times massage therapists think about how we just relax muscles and how we just lengthen muscles, but we are allowed to have clients do active movements. And we're allowed to have clients do active movements against our resistance. And sometimes if we've got a weak muscle at play, that's the best thing to do, right? We want to strengthen the weak muscles and lengthen the over-tight muscles and the fascia. Yes.
So is it so much of practice, say when the session's done, to make it such a soft suggestion of, hey, what if you did a couple of these exercises daily for 15 minutes or whatever?
Yeah, stretching suggestions is completely in our scope of practice. Giving exercise directions is a bit of a gray area. But if it's a more of like a stabilizing kind of a thing, you can. But what I do say is to definitely always defer, like if they're seeing a PT or an OT or a trainer, right, to kind of defer to that. But like if they're not doing anything for that, right? You can first of all recommend to those other sources, and you can recommend some simple kind of stabilizing exercises and so forth.
You just tag that on, you just say, you know, definitely you can go PT for this, but also there's a couple exercises here.
Yeah, PT, OT training, you know, even like, hey, do you like certain kind of workouts, right? You belong to the Y, there's all kind of free classes. Do you like Pilates or yoga, or, you know, things where they're going to have the opportunity to strengthen and balance and, you know, yeah. Otherwise you can, you know, show them a few. Yeah.
The serratus, how do you fire those guys up?
Let's wait till we get to the serratus. We got a lot to learn here. No, you don't have to apologize. All right, so traps. Traps. All right, so we abbreviate trapezius traps, whether it's a chart note or in common speaking. This is often called and is the most superficial muscle in the back. Sometimes people wonder, rightfully so, well, aren't the lats superficial as well? Down here in the bottom are the lats, and you can see that right under the skin, most of the way the lats are superficial. But on this tiny corner, the traps cover them. The traps win for superficial. So this whole traps are a very big muscle in terms of the area they cover. And of course, we're always talking bilateral, right? We've got a left and a right. So when we put them together, they make this trapezium shape. And, you know, we think of probably the trap sort of as this big, strong muscle, right? Because everybody gets tight up here and they want their shoulders rubbed, right? That's the upper traps, and they're pretty significant. But when we get to the middle and lower traps, that's pretty thin. And so that's thin to the point where a lot of times you don't really have to do much when you're massaging to kind of warm up through it and get to the muscles below it. Are there questions so far? Yes.
We're doing that shoulder lift,
Yep.
that's working out more than just the traps, right? That's also getting on the, okay, so what's beneath the middle and lower fibers of the traps? Are those deep muscles, deeper muscles?
Are you like talking about the middle traps?
Yeah. You know, when we do the,
Oh, and what's deep to them? Yep, the rhomboids and the ESGs, and yeah, so that's we're often, this is a great question, you know, we're often massaging kind of through multiple layers. Yeah, and it's really easy to like get right down to those rhomboids in that middle trap area. And actually that leads to, you know, that's one of the reasons why it's so good to picture the direction of the muscle fibers, because in most areas when the muscles are layered, you know, we'll have some going in this direction and some going in this direction, some going in this direction. And many times it's very palpable which layer you're on based on which direction the fibers are. Now, sometimes clinically, these things kind of get glued together, and especially if somebody is not athletic, like a couch potato, that's just an expression. So somebody who's not active, right, a lot of times has this gluey mess of muscles and you can't feel the direction, right? Or they just have this big mess of knots. This is another reason it's good to be able to know what the layer of the fibers are, because you're kind of sculpting them out, right? And it starts as this big gluey mess where you can't even tell the fiber direction, but you know that this layer is supposed to go like this and the next layer is supposed to go like this and so forth. And as you tease it all apart, you can start to unbury those layers. Yeah.
So sometimes you're sculpting the flow of the direction of the muscle tissue, but then other times when there's a trigger point, you want to do cross fiber, is that correct?
Yeah, we'll learn different times to go with the muscle fibers and when to go against the muscle fibers, yes. But in general, when you go, if the fibers are going this way, if you palpate across them or perpendicular to them is generally a good way to palpate which way do the fibers go. Because if you go with them, a lot of times you'll just get lost. But then treatment techniques, yes, sometimes we go with them, sometimes we go against them. Yep. All right, cool. Let's look at the traps in detail. So the traps have, and I'm now on the slideshow for those of you in the Canvas. And for those of you that are in textbook pages, we're on the pages. Nope, we're further than that, Anna. We're on the PowerPoint. Thanks for showing. So right now I'm on a picture that looks like this. It's in the PowerPoint, and if you're in a trail guide, you want to be on the page that shows the origin, insertion, and action of traps, because we're about to head into those details. Okay, so I'm actually gonna, and then I'm actually switched to the next page. We want to be on the one that actually shows the origin, insertion, action. And on the PowerPoint, let me see how many slides in it is. So your first slide, the first slide is going to look like this. We're taking a brief pause here while folks find where we are.
58.
Does the muscle start? I always like to start with origin, where the muscle starts, then insertion, where the muscle attaches, and then now we can look at the fiber direction after that and then see what directions would that shorten. So I always look at actions last. So remember origin, you know, if you're using color when you're taking notes, which I personally learn well that way, so I would recommend, origin traditionally is written in red. So if you want to like draw or even just use your words, right, or highlighter, and we have, those drawers are full of markers and pencils if you want to do color. So our origin is really big on the traps. And I'm going to just kind of pull up this model because it's so big. I'm going to kind of show you on a model as we go. There's so many words here. The first word there, the external occipital protuberance, is often abbreviated EOP. If you feel the middle of the back of your head and you slide down, the EOP is the bump in the middle before the ledge. There's a bump in the middle of the back of your head. And then if you go to either side of that is the superior nuchal line. And the thing about this is that it's actually quite bumpy and rough. So it's not like it's shaped a little bit different on everybody. But if you go across or lateral from there, we have this whole area.
When you say bump,
Yep.
the back of my head, there's the line.
Yep.
And then there's like a valley in between. Is that what you mean? It doesn't go out, it goes down. There's a depression.
All right, here we go. So our EOP is this bump up in the middle, and then our superior nuchal line. And in the palpation video, he gave a cue to go across from the top of your ear. So if you start at the top of your ear and you feel back for that bump in the middle. Now, when you actually palpate the trapezius, and you can try this on yourself right now, you know, where you start to actually feel the muscles are a little bit lower than that, right? But those tendinous attachments weave all the way up into there. You're sitting in a position that's harder to palpate as far as like releasing them for a massage, because your traps are holding, you know, helping hold your head up. But when the client is resting on the table, that all kind of softens and you can, you know, work your way into the tissue. We'll spend like lots of days just on the neck because that's a more challenging area. Yep.
So when I put my head forward and
Yep.
kind of down,
Yep.
am I feeling bad or is that something else? I can feel, is that the trap?
What are you feeling?
Your brain's still-
Something raised out of that valley part that I talked about that's below the nuchal
bone.
Is it right in the middle or on the sides?
It's in the middle where that valley is.
So in the middle are the spinous processes of your bone.
Uh,
But on the sides, when you do that, if you go forward, you'll feel kind of bumps, and that can be the traps.
oh,
So you can grab your traps, and they'll stick out more. But some people have a lot of tight neck muscles. Just making sure if this is one of your classmates. Okay. All right. So we're still on the big origin here. So let's work our way down. It goes down to the ligaments nuca, which is also said nuchal ligaments, 2 words for the same thing. And what that refers to is in the entire cervical spine, on top of the spinous processes, which is the part that sticks up in the middle, is a ligament that covers that whole area. Now on this model, it's kind of exaggerated. This is how thick it would be like on a horse. You can feel on yourself or a client that ours is much thinner than that, because you can actually kind of feel the spinous processes. It's not a giant ligament, but basically because of that cervical curve, there's a little ligament on top of it. And so traps attach right up the middle of that.
that's what I was talking about.
Great. And then we then go from the spinous processes of C7, that's cervical 7, through T12, which is thoracic 12. And so we count the segments of our vertebra superior to inferior. We start each segment with 1. So the top of the cervical vertebra starts 1, C1, C2, C3, C4, C5, C6, C7. Then at thoracic, we start again with T1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now, very easy to feel C7 on yourself, cervical 7. If you feel at the base of your neck in the middle, there's a bump that sticks out. That's normal for C7 to stick out. Some people it sticks out a lot, some people it sticks out a little.
That's a nice marker.
It's a great marker. So that's C7, yeah.
And that's the one that gets even more protrude.
Yes, yes. Okay, and then T12, we're going all the way down. T12 would refer to the last vertebra that the ribs attach to. So basically the bottom of the traps attach in a triangle like so. And that's the part that's especially thin. So you'll notice even on a client who is, got a lot of muscle and not a lot of fat, that even their lower traps are going to be quite thin compared to their upper traps. So that's a very long origin, right, by words. But what you want to do is make sure you know what all of those words mean. So any question on the origin words? Yeah.
How about like it's supposed like it starts from cervical 7 to 7.
Yep.
How about 1, 2, 3, 4 until 7?
Great question. So the reason they don't say C1 to C7 is because of this nuchal ligament on top of C1 to C7. So it is in effect attaching right in the middle, right to C1 to C7. It's just that they're referring to attaching to this nuchal ligament, but it's going right on to the C1 to C7. Does that make sense?
It's like ligament and then muscles.
Exactly, exactly.
That is attaching to the ligament.
Exactly. So it's just a little thicker in this area, which is why they're calling that out. But that same ligament actually changes name, but keeps on going. So the entire spinous processes actually has a ligament covering as well. It's just a little thicker in this area.
From C7 to thoracic 12, it's attaching to the ligament to the process, spinal process.
Exactly.
Okay.
Exactly.
So
Yep.
put the trap in over it? Is that what you're saying?
It attaches to the ligament, which attaches to the spinous process.
Put the trap over the-
Yes, except the ligament is like in the mid-sagittal plane. So it's, attaching into it like that, but yes, on it. I'm going to pause for just a So this is just a model of the spine. And so these parts that stick out in the back, and if you feel on yourself, you can feel almost every one or every one right in the middle. These bumps are called spinous processes. So these are the prominence that the muscle is attached to. And there is a ligament on top of those. So it just attaches onto the ligament, which attaches to the bone. Yeah. So question? Any other questions about those origin names, right, that are quite long? All right, let's look at insertion, which should be quite easy because we already learned it. So the insertion is the lateral third of the clavicle. I'm drawing in blue right now, the acromion process, and the spine of the scapula. And so that insertion of traps, like we looked at, is the origin of deltoid. And so they're going to weave in, right, via tendon. So we've got the muscle fibers. I made little models. They're very simple models. But in this model, right, the muscle fibers, you know, are in red, and we can feel these fibers, and they always have a tendon. So the fibers weave into the tendon, and that attaches to the bone. And so that's how we're attaching onto that same origin of deltoid. Questions so far? All right, and so the traps, like the deltoid, and not all of the muscles are this complicated. Some of the muscles are very straightforward, only one section, just a few movements. But we're looking at a couple muscles to start with that have big origins and or insertions crossing from multiple angles. So they're like 3 different sections. Not all the muscles that are complicated. So with the traps, we have 3 separate sections. The upper fibers, and that's that part that we feel up here that we massage, but now we know it goes all the way up to the external occipital protuberance and the nuchal line. Great job palpating on yourself. This one, if we bilaterally, which means left and right side, both contract at the same time because they're pulling from the back, we can extend the head and neck. So when they say bilaterally, that just means your left and your right are doing the action at the same time. Because we can also just fire right trap or left trap. But we fire both traps because we're pulling from the back. We can extend the head and neck. Does that one make sense? Unilaterally means we're doing one side or the other. So we could fire right traps, we could fire left traps. So on this one, we can laterally flex the head and neck to the same side. So right now I'm firing, this is my right side, my right traps. So ear to shoulder is traps. That's called lateral flexion of the head and neck. So again, you want to keep in mind, like when you need to stretch a client, whether it's a passive stretch or a pin and stretch, these are the movements you want to keep in mind if they need this this traps stretched. When I move in this direction, I'm firing my right traps and I'm stretching my left traps. Rotating the head and neck to the opposite side, elevating the shoulders or scapula. So shoulders coming up, it's this one, that's upper traps. And upwardly rotating the scapula like so. And again, remember, our deltoid gets us to here with abduction, but then we need our upward rotators to get us the rest of the way. Great job doing all the movements, everybody. It's a great way to learn is to keep palpating and keep moving. You're doing a great job. I wanted to call out, about this elevation of the scapula. You know, so there's certain of these movements, right, we see clinical implications of frequently. And a lot of folks hold their tension in a lot of different ways, but one of them is to kind of elevate the shoulders up And so that means the traps are short and tight and firing too much. So that's a situation where we want to relax those upper traps. Perfect. Yes, I see multiple people making the connection right away that this movement that we've been doing helps with that. Beautiful. Great job. All right, our middle fiber. So this is the part of the traps that gets overworked, overused the most, and gets short and tight the most. The next two sections actually tend to get underused, long and weak. So we tend to need to strengthen them more. So the middle fibers abduct the scapula. That is scapula towards the spine. Do that better. Adduct scapula towards spine. And hopefully you can see that if the medial fibers are coming in between here and here, like I could literally like put holes in this and attach it. And if I pulled in this direction, right, that's adduction, these fibers. And they also stabilize that scapulothoracic joint. Now, the reason this one comes up so much as being long and weak is that, you know, with the use of phones and computers, laptops, etc., or just studying at your books a lot of people end up slumping. And when you end up slumping, if I turn sideways, you can see that I also medially rotate my shoulder. I pull my scapula forward. So my scapula are not by my spine anymore. They're away from my spine. And so in that tech neck slump shoulder position, we have that long and weak. Question?
Are the upper fibers of the trapezius inserting at the first rib at all, or no?
They are not. No, we're going to look at scalenes insert there. Yeah. Yeah. Yes, Anna.
And I'm sorry, you were
Nope.
saying it's the mid-traps that are weak?
Mid traps and rhomboids. Yep. Yep. Because they're supposed to adduct. And so when we are in a position that's abducting a lot, they're not getting a good workout.
They're just hyper-stretched all the time.
Exactly. And the
Makes the traps tighter.
the pecs are pulling forward, right? So you can do that movement right now and feel your pecs and you can feel them pop out, right? They're getting tight. And, but you'll notice that a lot of clients have pain and soreness and tension feelings in the middle of the shoulders, right? Where you have those rhomboids and middle traps. So even though they're stretched long and weak, they can still cause pain. And so, but we're going to address them a little bit differently, right? We can do things like release the trigger points without stretching them further, because we don't want to make them go any further this way.
Does releasing the trigger point change the length in the muscle?
Yeah, that's a great question. It can be part of what helps the muscle relax, and then we can also lengthen the connective tissue and muscle to make sure it stays long. Yep, yep,
Sorry.
yep.
So
Nope, you're good.
you wouldn't, push out,
Yep.
you wouldn't do that?
We wouldn't want to do as much of that, right? Like
Or just, straight down?
we'd want to do more releasing it against its fibers or straight down, and not as much stretching it out. But if you're really focused right on you know, the ESGs, it's still okay to push in that direction. We're just not trying to take this medial border of the scapula and really like stretch that out even further. You guys are doing great with your questions, you're connecting things, thinking, palpating. It's great to see you so engaged. Yes.
So is this a possibility? Because I do have that tightness in the round, especially since I sleep on my side.
Yep, yep,
Or sides.
yep.
I wake up, all this is wrinkly.
Uh-huh.
But simultaneously have, they're not mutually exclusive, that you could have too much stress in the back in the mid traps, but however your scapulas are almost fixed a little bit and they needed to be unhinged a little.
Yeah, you can definitely still have your scapula kind of glued in place.
Because I think I have both of those things.
Yep.
And I had a massage therapist actually recently who, not here, who was trying to do that and pulling my scaps up, which is pretty nice and painful at the same time. But definitely that back area is hyperextended.
Yep. And you can have those at the same time. And I love to do scapular mobilization.
You
It's,
just
you
grab
know,
that thing and pull it.
you can get, you can get under there.
That sounds a little scary.
It usually scares people at first when they see it, but because we have all these muscles kind of fixated on all the edges, it can feel good to, and again, if we look at and think about how much motion this should have, if it's not like, that's part of what we want to really increase the range of motion, right? Again, a lot of massage therapists sometimes focus just too much on making things soft, but we want to think about functional improvements. So like if somebody is really limited in their shoulder movement, right, we want to free things up in a way that they're actually able to move better and in less pain. Yes.
So with that follow-up, this same massage therapist said that my thoracic spine was extremely, oh shoot, I'm forgetting the word.
Kyphotic,
I didn't even hear what you said.
kyphosis.
Okay. That it was extremely restricted, that the mobility, there's just like no mobility.
Yeah.
So there was a relationship with the restriction of the scapula and the spinous process and all of that, and then yet still the hypermobility of the mid traps. I'm just painting a picture,
Okay, cool.
just trying to figure it out.
Yeah, that's great. That's great.
Gotta do some.
Good job putting all that together. Yeah, I was just gonna say that. Mary said rowing, and that's one of my favorite things to do in the gym. And I'm calling this out because not only phones and books and laptops do this, but massage, right? So we're like this a lot. So we need to get like this. And so a rowing machine, when I row or do any of the machines, you know, the ropes and things to tug on, right? You know, you want to focus on, when you do those movements, pulling your scapula back. And it can be hard to engage muscles that are sleepy, right? So, you know, another one that you can do is like hold a medicine ball or an imaginary ball and pull the scapula back as you bring your arms back. Clients can do this when they're laying on their back. Clients can also do this when they're laying on their back with the towel rolled up in the middle of their spine. So they really practice that engaging, bringing those scapula back. And that's hard work, right? To engage those sleepy traps and rhomboids.
I know massages now. So they move their arm
Yes, I will show you some really fun, great moves. I mean, I love that work. I don't know if you can picture with this scapula, but like their arm would be here. I like to do a lot of things where the arm would be this way. And so the client is like face down here. I like to do a lot of things where I pull from this side and really lift this up. But again, keep in mind, if you're doing it passively, that's still not having them shorten those muscles. But we can do a lot of things to free up the fascia and the restrictions, but then we still need them to learn how to use those muscles again.
I saw you do that in one of the Swedish videos, and it's almost like you're giving it a bear hug and pulling it all towards you.
Yeah,
Almost like holding the deltoid.
gather the whole thing up.
And you pulled it all towards you. I was like, oh, that looks good.
Yeah, it's really awesome. And you know, a lot of massage therapists will like have the client put their arm behind their back. And I think that's a problematic position for obvious reasons. Torture by siblings, handcuffs, physical assaults of all sorts. And so I don't ever put people's arms behind their back. Some massage therapists will do it and then ask if that's okay. I don't do that. I can get just as much or more range of motion doing all kind of other things that never have the person's arms behind their back. Yeah. And in fact, this freezes. If you're comfortable trying this on yourself, this locks this into place right now. Whereas we're going to do mobilizations where none of that is locked up. And it's very fun. It's very, very, very fun. I love that work.
I really respect that.
Well, and we've been sort of learning it in little bits at a time, but we'll have whole classes that really just look at all aspects of trauma-aware therapy, but we just keep sprinkling all of the aspects in, right? Okay, and so the lower fibers, right, if we're pulling from below, we can depress the scapula and stabilize the scapula. And again, because so many of us are jacked up, these are also muscles that can be sleepy, is bringing our shoulders back down, right? And so those are other ones we want to engage, like whether you're at a gym or, whatever activities you're doing, you want to engage those. We started with two big muscles, right, that have three different unique sections, which is complicated. A lot of our muscles will be like more of a straightforward line. And if you're only pulling in one line, we're talking about one set of actions, right? And not all of these complicated different muscles basically crossing. So you're doing a great job hanging in there. All right, so I don't want us to stress out about all of the synergists at this point, because again, it makes more sense as we learn more muscles. The only reason I walk through those beginning ones is to get you to start looking at this, but I don't want your minds to explode looking at all of the synergists here. So we'll kind of come back to that later.
Could I ask if anybody knows the page that the synergists are on? My computer died.
Okay, so Latissimus dorsi is abbreviated LATS. People say LATS, and it's also your abbreviation when you're doing a medical chart. You want to write it. The lats are often nicknamed the swimmer's muscle because they're such a powerful extender of the shoulder, that swimmers get this, big beefy lats that you can see right here. So if you feel behind your axilla in front of your scapula, you can feel a big, strong muscle. And if you extend your shoulder, you can feel it get hard. It's a little further back. There you go. That's it. And you can see in the pictures, it goes all the way down to the hips. But right here is where you can feel it the best. Right at and under the scapula lateral border is where you feel it the best. Well,
No, it came from the ribs.
It crosses them. Yeah, it comes from the ribs and crosses them. Yep, yep. So when you feel like this whole big wall is lats. Yep, yep, yes.
Is it more tender here on the left just because of the ribs?
Yep, it tends to be tender. Haha, mine is because of my upper body workout. Yes, it's usually more tender on the deeper muscles. It looks like are you right in front of the lats on serratus anterior because it attaches to the ribs are very tender.
Yeah.
Yep, yep.
Boys don't like it if I rub them there either.
Yeah. All right, so as I like to start with origin and then insertion and then actions. So origin, this first one is very, very, very minor. The inferior angle of the scapula is kind of not a big deal. Spinous process of the last 6 thoracic vertebra. So T6, 7, 8, 9, 10, 11, 12. So that again is spinous process is this part that sticks out on the back. So we're talking about the last 6 of the ones that the ribs attach to. So the lower ones that the ribs attach to. And then it goes all the way down to the last 3 or 4 ribs and all the way down to the thoracolumbar aponeurosis. So on your diagrams, right, the aponeurosis is where it looks more gray or white, is indicating tendon. And then all the way down to the posterior iliac crest. So all the way to the top of the back of the hips. So while this crosses the glenohumeral joint and is very powerfully acting on the glenohumeral joint in extension, we're talking about a muscle that actually attaches all the way to the hips. And so again, if we think about like gymnasts on, bars or rings, or, we're talking about a muscle that is strong enough if you're stabilizing your other shoulder muscles to actually be acting on your hips as well. But we're in everyday use more talking about this action on the shoulder. Our insertion is the intertubercular groove of the humerus. So, when we study the upper attachments or bony landmarks of the humerus, we talked about this, the bump of the greater and lesser trochanters, tubercles, and this groove in the middle is the intertubercular groove. So the what this diagram of these fibers is trying to show is that these fibers start from the back and twist around through the inside of the arm to attach here. This is a very tender place to massage. So I don't recommend actually massaging here, but we can do a lot by releasing this part of the lats. But I just wanted to call out how it twists around and goes in front of the arm, because that's how, it can add to this, this extension. And also because it twists around to the front and comes from this angle, can also medially rotate the shoulder because it's pulling. Yeah, great. You guys are acting it out. So it's pulling like this because it goes from in here up this way to here. So then it can pull this way.
Wait, show the beginning of that, please.
Sure. Well, here's a lat that I built for a big full-size model. So this part right here twists and attaches through the arm from here. It wraps around here and attaches up to here. So it comes around from the inside and attaches up to here. And so this can, when it pulls, it can medially rotate. And also adduct. Do those motions make sense, or do you want to talk about any of them? They're going to stabilize in that movement or pull back, right? But the one that goes forward is more serratus. Yeah, but you need them to pull back fast, right? Yeah. Awesome, thinking things through and making applications in your mind, folks. I didn't mention this on the earlier ones, but I do want to call out that we do not memorize every single nerve. So that N is nerve. You don't need to memorize every single one. What I'll do instead is call out the ones that are more common. And then when we study for our licensing exam, we'll take a peek at that as well. Yes, question.
Wait, does the Latissimus Dorsi overlap the bottom of the trapezius?
Great question, vice versa. So at the bottom of it, the traps goes on top of it a little bit. Yep. Yep. So if the bottom sort of triangle of the traps crosses a little bit of the lats, and it's the one on top. Great question. It looks like the traps are very thin right there, so you don't really see it or feel it on a client unless, like in the palpation video, when he had the person put their arms up and forward, that kind of makes the bottom of the trap stick out a little bit. Some people have this like thin little angled border that you can palpate a little bit for their traps. All right, so let's move on to teres major. Yep. All right, I think teres major is pretty straightforward. Important muscle. Sorry, I thought that was on the same slideshow, but it's not there. Yes.
Oh.
All right, so teres major, first thing I want to say about teres major is that didn't make a sound like it heard me. So let me try again. Bup, 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 bup.
It almost looks like a dorsal.
So teres major and teres minor, or excuse me, sorry, teres major and lats. The reason these two are grouped together is that they're complete synergists. The difference between a synergist and a complete synergist is that a synergist is just they have an action that they do the same of. So let's say they both extend the glenohumeral joint. A complete synergist is they have all the same actions, right? So, you know, you could think about how to have all the same actions, they would need to be pulling in a very similar direction with a very similar line of force. So indeed, if you look at the pictures, where our lats come in, and I can draw one here, I'm drawing on the bottom left, dude. We have these lats, the teres major coming in at, you know, basically the same angle as the lats. They're just, you know, a lot shorter muscle segment, right? Like so, instead of going all the way down to the thoracolumbar aponeurosis and the crest of the iliac. Yes.
Not to jump to another muscle, because I've done that before.
All right, all right.
Just looking for a relationship here.
Yes.
So the teres minor, is that underneath the lat and it's kind of going a different direction?
That's a great question. So teres major is on the inferior aspect, or it attaches to the inferior aspect of the lateral border of the scapula. Teres minor attaches way up high, close to the armpit in the superior aspect.
So is that teres minor that you drew there?
I drew teres major in red, and then teres minor would be like, you know, tucked up even higher.
Oh, okay.
Yeah. And the difference here, and this can be hard to look at in a two-dimensional drawing, which is right why we sculpt them and so forth, is that teres major is going to, just like the lats, when it comes around from the back, it's going to wrap, oops, that's hard to do with such a short one. It's going to wrap up around the front to that same general area. So it's wrapping up to the front, which is how it can have that medial rotation and all. As opposed to later on, we'll come back to teres minor, attaches in the back. So it's not going to pull this way, it's going to pull this way as far as rotation goes.
Its origin or its insertion is on the back.
It's origin, because this is the less mobile side, is the scapular side, and then the glenohumeral joint, right, the appendages are the more mobile side. Yes.
Sorry.
Wait, I think that's the complete synergist.
Yeah.
Yeah, no, but I'm just laughing because the popping food in the masks is hilarious. You didn't catch what a complete synergist is? So a synergist, right, is just if they share an action, like extension of the shoulder or whatever. A complete synergist is that they all have the exact same actions. So in this case, the lats and the teres major all extend, adduct, and medially rotate. Now here's a super cheesy mnemonic, a way to help, because you're going to have to keep teres major and minor straight in your head and not confuse them. And so this is kind of cheesy, but teres major and lats both do all the actions that put you in a handcuff position. And so if you're in handcuff position, you're in major trouble, right? So it's major that does that, not minor.
I think that's how I might remember it.
That might be how you remember it. All right. So we didn't study the minor yet. We're not there yet. It laterally rotates instead of medially rotates. Because it attaches in the back instead of the front.
Of course.
But the other actions, they do the same because they can both go like this. Yeah. All right, teres major. Woo! Okay, so I apologize. Somehow this doesn't have a slide with the origins on it. But origin is, I already drew it, but it's up down here, the one in red, inferior angle and lower third of the lateral border of the scapula. So inferior angle, right? It attaches here, and the lateral border on the inferior third of it. So remember, like on your MBLEX, they might not use the exact same wording, but like if they said like the inferior aspect of the lateral scapula, that would mean the same thing, right? Even if they didn't say like by the third and all that, right? So it originates right here. It's tight on almost everybody. It's very palpable. You can feel it, right? So we find this inferior angle, which we can isolate, like, you find this, and then you walk your way, and this whole part right on this border is the teres major. And it's tight on everybody, right? So this lateral border, we go from teres major and then teres minor, and both of these get jacked up. And so it's one of those areas where you can just go to on everybody, and it's tight, and they'll be like, oh my God, how did you know? And at that point you can be honest, or you can, just seem amazing beyond, wonder. Yeah. Which is both true. There you go. Both and. All right. So our insertion is the crest of the lesser tubercle of the humerus. So very, very similar to what we just looked at with the lats. If you recall, the lats were actually like in this intertubercular groove, right? Which again is sensitive. You don't really want to massage it. But the crest of the lesser tubercle is just, again, you're not really going to massage right on it, but it's just kind of right below. There's a rough spot. And, they're attaching it almost the exact same spot, but just because they have to actually physically attach to the bone, they're just not right in the exact same spot. So we have these two tendons right next to each other. Does that bring up questions so far? We're flying through here now. And these are sort of minor nerves. You don't really need to memorize those. Yeah. But these are two muscles that we're going to massage a lot. And we didn't learn all the pin and stretches yet, right? We didn't learn all the pin and stretches yet, but this one's pretty easy to, you just pin right there on the lateral border. And the movement is a little counterintuitive, but when the person is laying on the side of the table, you can just alternate. When you go like this, it alternates between lateral rotation and medial rotation. And if you can get your whole hand on, well, it's really better just one at a time. So you can have on teres major, beautiful job trying it, everyone, medial and lateral rotation. Then you work your way up to teres minor. Is quite high and harder to find on yourself, very easy to find on your clients, and then the same thing, right? Questions?
Really tender to the touch.
Yes, thank you for calling that out. This one does tend to be very tender on people. So the ones that we kind of know are going to be tender on people, you just want to take a little extra effort to make sure you warm them up, and then go a little lighter, right? Like if I'm trying to think of something that would be not a confusing model. Let's say I'm cruising along and this is the client's bone and this is their muscle. It's a silly model. And I was like, this is a 7. If I'm cruising along and I get to one of those spots that tends to be tender on folks, like a deeper muscle, a muscle attachment, a trigger point, etc., then a 7 in that area is going to be like, I'm exaggerating, but it's going to be not as deep, right? So I'm calling that out just because when you get to those spots that are tender on most folks, you approach them with caution, right? So you wouldn't go into your normal 7, you'd go into an easier 7 and you check in with them. Yeah, yes.
So what makes that one tender?
That's a great question. I suspect it's because it's right there on the bony attachment, and it's tight on pretty much everyone. And I think this is because it is, this is a little advanced. It's an introduction to a topic. There's 2 kind of primary types of muscles, phasic and postural. And the phasic ones are meant for fast temporary actions like biceps brachii. This one is not intended as a postural muscle to help you stay upright all day. But sometimes we make our phasic muscles behave like postural muscles because our posture is out of position in a field of gravity that makes other muscles having to hold on for dear life. So going back to this, like, I would normally walk around a lot more, people, sorry, I'm trying to stay in camera. But going back to the classic posture of tech neck and looking at phones, looking at laptops, looking at textbooks, I'm exaggerating, but my posture is not much better than this on a good day. When we start going like this whole arm is thrown forward. And now all these babies are holding on all the time, right? As opposed to if I'm like this and my shoulder is in line with gravity, there's more balance involved and less muscles holding on. It should be, your ear should be over it too, right? I wasn't talking about head forward posture, but yes. Yeah, does that bring up questions, comments, interpretive stances?
Yeah, just has to do with alignment.
Woo, we got a couple.
Alignment to make it more tender too.
Yes, yes, yes. Uh-huh. Yep. And we'll see that a lot. And a beautiful, beautiful, we're going to get to myofascial release and all these great ways we can really like open up the fascia in these patterns where it's normally stuck. All right. So, and we already talked about the movements because this is the same as the lat. So let's move on. Last muscles of the day, and then you'll have a variety of ways to practice and work with these. Okay, I think this one's still today. Yeah, no, we're done. We made it through all of them. Hooray. So I'm gonna give the directions quickly so the remote folks get them too, and then I'll put this on pause while we do them. We're gonna do 2 primary activities before we come together, and I'm gonna tell you both of them in case you have a preferred order. The worksheets that I handed out yesterday, the first packet, some of you are already using them, and that's fine. Could somebody grab me a picture with the bones on them? Thank you very much. So you're going to take the picture packet of that has bones and OIA. Can you bring it here so I can show our remote folks? Should have taken this home yesterday. Yeah, thank you. This drawing the muscles. Each muscle also has origin, insertion, and action. And it's got a good view with bones to help you be able to draw your exact origin, insertion, and action. What I would recommend is that you draw your insertions in red and your origins in red and your insertions in blue, and then draw the muscle between. You don't have to use color, but it might help you to start separating your origin insertion. We do have craft drawers over there that have pens, pencils, and crayons in different colors if you want the red and the blue. I recommend kind of drawing and writing what you know in your head before consulting with your book and your classmates. You can also, of course, feel these things on yourself and your model. Yes, that's what I've got on that. And then the other step is that you're going to sculpt these in clay. And we're just doing a couple muscles here today. We're doing this teres major, which in this model is pink. We're doing the deltoid in this model is orange. We're doing the lats and then traps, which are not on this model. But since it's your first day really sculpting muscles, I just want to call out that, of course, you want to sculpt the deep ones before you sculpt the superficial ones, right? So teres major has to be sculpted before lats and traps. And so you're going to build your traps last, right? What else do I want to say about sculpting? Everybody has a different style, right? There's no right or wrong, except you want to really make sure that you're going to the full origin and insertion. And then it can be helpful, but not required, to kind of also sort of sketch in, you know, your muscle fibers. So you kind of keep practicing, like, what direction do those fibers go in? I'm always happy to check your drawings and your sculpting, not to grade you, but to just help you in case you're sort of misunderstanding any of the origins and insertions. And I recommend you sculpt in different colors, but it is definitely not required. So I'm going to pause this. Are there any